next is Dr. Paul Bunn, and he's a distinguished professor and the Dudley Chair at the University of Colorado Cancer Center. And he has innumerable accolades, and that will fill all 4 days for us to talk about. And he'll be talking about what genomic testing should be done in early stage non-small cell lung cancer.
Thank you very much. I'd like to thank the organizers for inviting me. The title and the conclusion of my talk is the same. What genetic testing should be done in early stage non-small cell. So it took us many generations to evaluate chemotherapy in early stage disease. And chemotherapy was first done in the adjuvant setting, but subsequent to that was done in the neoadjuvant setting. And meta-analyses of both adjuvant and neoadjuvant chemotherapy showed very similar hazard ratios and very similar effects on survival. And it's not huge, but it's statistically significant. If you look at adjuvant, the hazard ratio is 0.89, and if you look at neoadjuvant, hazard ratio is 0.87, about a 5% difference at 5 years. So when TKIs first came along, it was not surprising since the response rates were actually higher than with chemotherapy in mutant patients that they might be looked at in early stage disease. And one of the earliest trials came from Memorial Sloan Kettering, and they did not do a randomized trial. They just gave a number of patients that had a mutation, gefitinib or erlotinib, and then looked at their outcome compared to historical results. And they said that maybe it looked promising. And then this trial was done at Stanford and elsewhere, and it was also a single-arm study. And this in this study, patients got erlotinib for 2 years, and then it was stopped. Now, one of the things is a number of the patients wouldn't tolerate it for 2 years and stopped it early, but most of the patients got it for the 2 years, and you can see there were not a lot of relapses during the first 2 years. But as soon as the TKI was stopped, you can see about 60% of the patients progressed in the next year, suggesting that they weren't cured. And as soon as you stop the drug, they would relapse. And the cure rate there looked, potential cure rate looked not that dissimilar from surgery. Now, the patients who relapsed, they put them back on drug, and so their overall survival was pretty good. So depending on if your glass is half empty or full, different people have different interpretations of this. So then there was a large international randomized trial of erlotinib after surgery, and that was called the RADIANT trial. Now this trial accrued patients who were wild type for EGFR and patients who were mutant for EGFR. And these are just the mutant patients, which were a small minority of the trial. And you can see that during the treatment, just like in the SELECT trial, there were fewer relapses on patients who are getting the drug, and more patients here than in the SELECT trial actually dropped off for toxicity. But you can see that once the drug was stopped, the curves came together. And up until 3 or 4 years, didn't seem to be any difference in overall survival. And so once again, some people, if their glass is half empty, have said there's no way this is going to improve survival. And some people have interpreted this showing as there's potential benefit, especially if you keep people on beyond 2 years. Now there was another randomized trial, and this came out of Canada, and in this case the TKI was gefitinib, but early on when this study was started, Karen Kelly published a paper showing that gefitinib had a worse survival when given after chemoradiation. So this trial was stopped early, but it also did appear in this trial that the patients that were getting gefitinib actually maybe were doing worse. But the caveat is they weren't really treated very long, and they may have had a flare after they stopped. So to answer this question, there are a number of ongoing randomized trials around the world, and presumably at least a meta-analysis might be able to be done when all these trials get done, if they ever get done. But here are some of them. In the US, all the cooperative groups are participating in this trial in which people are sequenced in the beginning, and the plan of the study is to sequence, whoops, I did the same thing everybody else did, was to sequence 6,000 or 8,000 people. And then those with an EGFR mutation would be randomized to get erlotinib or placebo. Once again, however, 2 years. And those with an ALK fusion would get crizotinib or placebo. Now, this trial, one can question whether it'll ever come close to reaching its accrual goals or not. But presumably there'll be some data generated that at least might be able to be combined with some of these other trials. So the Japanese have this trial, which has been going on for some time, randomizing people with an EGFR mutation to gefitinib or platinum doublet chemotherapy. The Chinese have a very similar trial, gefitinib versus multi-agent chemotherapy. And certainly, do we need all these trials? And what are these trials going to show? Again, if we look at GIST tumors, as soon as you stop the TKI, the tumor will recur. Remember that when we give these TKIs, although the response rate is 60 to 80%, complete responses are essentially nil, right? So if we have 10 to the 12 cells, we kill 1 or 2 logs. The other 10 to the 10 cells are sitting there. And as soon as you take the TKI away, those other 10 to the 10 cells grow. And one could argue that it would be unlikely that these treatments are actually going to cure anybody, and I'll give you my bias at the end about what we should do about that. So obviously you're jealous of all our molecular targets, and there's a number of them. So the question is, besides EGFR and ALK, should we be testing for all these? Because most of them represent 1 to 5% of the pie, and if we only treat 1 or 2%, are we going to get anywhere? It does appear that people who have a driver and get a targeted drug live longer, but it doesn't appear that they get cured. So coming back to the question, the first question is, if we're going to do mutational testing, what mutational testing should we do? And probably a simple one would be do all those tests for which there's a drug. And the number of drugs is around 20. And so, of course, Foundation Medicine gives you results back on 400 CLIA-certified mutations, but the vast majority of them don't have any drug. So many academic institutions and commercial companies have made multiplex platforms that test those that have a drug. And an example of one of those is here. This is not an advertisement. At our own institution, we have our own panel. But most of these panels have have drugs for which there's mutations for which there's drugs. But of course, the question for this talk, is it worth doing those for early stage patients? So there is a guideline, and the guideline is actually under revision, but the guideline came from the ISLC, CAP, and AMP. I like the way I spelled molecular. But the guideline says that molecular testing for EGFR and ALK should be done in advanced stage in everybody with an adeno component or in never smokers before treatment. But with respect to early stage, the guideline says that the testing should be up to institutional guidelines. And of course, that was a huge hedge. The advantage of that hedge is that you can put people on clinical trials like the ones that I just showed you. But my bias is that we have to find out why 10 to the 10 cells persist. Every one of those 10 to the 10 cells that persists have the same activating EGFR mutation. And so how are we going to determine a rational combination? The only way we're going to cure this disease at any stage is to give a rational combination. And so the question is, how are we going to find a rational combination? And there are a number of approaches, but this was one approach, which was to do a neoadjuvant study. And at an early time point, resect the tumor and find out what are the characteristics of the 10 to the 10 cells that are persisting. Unfortunately, this study may not be going forward because although the New England Journal believes that the response rate to ruxolitinib is 58%, the FDA believes that the response rate to ruxolitinib is 34%. And that's one of the things about all these waterfall plots. Those waterfall plots are not confirmed responses according to standard RECIST criteria. And we have to be careful showing those waterfall plots, and I think that's probably true for ruxolitinib especially. And we really need to know what the truth is when we have discrepancies between 58% and 34%. Now, one of the questions is, we've addressed PD-L1. Nobody can give any talk without addressing PD-L1, but the question is, of course, will we be needing to do not only molecular testing up front, but will we be needing to do PD-L1 or immune testing up front? And I only bring up this. This was patients in the original Pembro study that have PD-L1 staining in more than 50% of the tumor cells that got pembrolizumab alone. This is untreated stage 4. And there's a year, and there's not a lot of patients out past a year, but we don't have a lot of treatments where all the patients are alive at a year either. And so one could also have asked me, is genomic testing necessarily an early stage disease? And another question is PD-L1 testing required in early stage disease? And Dr. Carbone mentioned his study. It's going to be done by the LCMC, which is hopefully going to address that issue. And again, to find out which cells respond and which patients respond. And for those that do and don't, what's the difference? Just in terms of how all this plays out, this was the plenary session at World Conference, and this was a study of bevacizumab. Chemotherapy with or without bevacizumab is an adjuvant. And I just want to make a couple points. This study started in 2007 and was reported in 2015. And so these adjuvant large randomized trials are difficult and take a very long time. Just one other thing, is there stage migration in lung cancer? Well, remember all those curves that I showed you before, the meta-analyses, the five-year survival rates were 48%. And here, whoops, here you can see that the control group did better than historical controls. I suspect that's from CT screening and other uses of CT and better staging. But the point is here, it takes a very long time to do these large randomized trials. My own bias is we should be doing smaller neoadjuvant trials to figure out the biology of what's going on. And I'm going to talk about necitumumab tomorrow, so I won't show these. And next year, the organizers of this meeting need to understand that the World Conference on Lung Cancer next year is December 4 to 7. Hopefully everyone in the audience will be there, but hopefully this meeting can take that time frame into consideration. Thank you.
Very nice talk. I will repurpose Fred Hirsch's question for you for lung cancer. So obviously you have drivers and you have also immunotherapy. So how do you think the relationship, I mean, there's some data there for patients who have these genetic drivers and PD-L1, what do you think it actually means? Should we do both, or should we potentially only do genetic testing and not go further for those patients? And then obviously, other implications for efficacy with immune therapies in these genetic driver-driven tumor types.
Right. So, of course, whole exome sequencing was done by the group in New York, and the best biomarker so far for lung cancer response to these agents is the number of mutations. So the more mutations you have, the higher the response rates. Response rates are way higher in smokers than in never smokers. Responses are higher in males than in females. It turns out, of course, that people with the drivers tend to be never smokers, they tend to be women, they tend to be younger, and they tend to have far fewer mutations. That doesn't prove that the response rates there will be lower, but one might surmise that they might be. Now, obviously, PD-L1 expression is transient, it's not static, and there's some evidence that PD-L1 expression after a bunch of chemo and a bunch of other things that you do to these patients, it might actually go up in them. So my own belief is that we're going to do PD-L1 testing and molecular testing. My own belief is the people that have a driver are going to get a TKI, and people that don't have a driver and have high PD-L1 are going to get immunotherapy first. And there are combination studies going on, obviously, in lung, just like in head and neck. My own bias is that chemotherapy doesn't help immunotherapy. In fact, giving steroids and all the chemotherapy, my own bias is it's not a logical thing to be doing, but the time will tell. So I think we'll be doing the testing, but I think there's going to be a group that's getting PD-L1, and that's predominantly going to be people with lots of mutations, squamous, lots of smoking elderly. I think the mutant patients aren't going to get that until much later. Hopefully PD-L1 will be higher later.
So I don't think, Paul, the picture is so clear on that topic, because there are data, EGFR mutant patients seems to have a higher PD-L1 expression. Mutant tumors, several of them are done on preclinical models, but the mutant, EGFR mutant seems to have higher, and there are actually, I cannot disclose, but there are other studies showing that other drivers actually have higher PD-L1 expression too. So I think we need to learn much more about it.
I don't disagree. I was giving an opinion, not a fact.
Right, right. I love to discuss with Paul Bunn. It's wonderful.
I agree with David, but I don't think we know yet. But fortunately, there's trials. So.
Thank you, Paul.